to cloud. So just some order of business. So we'll review this week or today. Monday we'll continue with another review class. So we'll come to Riverside in person Monday. We'll finish up these review questions for vascular. I was thinking maybe doing like half of you do our clinical evaluation on Monday and then their half on Wednesday, just so like we're not there late on Wednesday. Wednesday will be the final. And then we'll have, I know, then clinical review, final clinical evaluations in the afternoon after the final. And then Friday is going to be our pathology research presentations. So Friday, 10 a.m. we'll have pathology research presentations. The final on Wednesday will start at 9 a.m. So we'll do 9 to 11 for the final. So I'll send out like a sign up for you guys, like to pick either next Monday after our review or after the final on Wednesday. So I guess for clinical evaluations, really, I think the only thing you guys need to bring are like the site evaluations. And I have to see if there's like a final clinical evaluation that you guys have to fill out, like it's kind of similar to that midterm one. But I think everything else now is on D2L, which is good. Just make sure your logs are up to date, when we have our meeting. I know, I see some of you smiling. Anyway. All right. Let's start the Jeopardy. Let's share our screen.
You're going to call on who's supposed to go, right?
Sure. Yeah.
You just want us to all yell at one.
Free for all.
Do we all get eggs?
So
Literally.
So Zoom's not good for free for all.
No, it's not.
It gets real weird. Did we try that with Kathy and it was like just awful?
It was terrible.
It was like so much reverberation. Nobody could hear anybody.
I'm trying to find this whole. Let's pause recording. Open. Where's my share? There she is. Alrighty. You guys can see that, right? Let's move this little guy out of the way. I want to start off, Krista. I'll just go down the way you guys are on my screen.
Sure. Did you want us to read the question?
Yeah, you can read it out loud. Yep.
Leg pain with exercise that is not due to arterial occlusive disease is often referred to as, would that be, I'm like in between B and C. Maybe B, I don't know.
No, definitely B. I mean, arteritis would be a form of arterial disease, arterial occlusive disease.
Mm-hmm.
So yeah, no, all the other choices are definitely forms of arterial disease. Yep, B.
Red arrow.
All right. Red arrow. So this is for Karima now.
Okay, this is the small saphenous vein.
Good. Yep. Also referred to as the stocking seam vein. So it runs down the posterior aspect of the calf, right in the middle of that calf. Let's see. This is you, Kim.
Great.
Great.
Oh boy.
Normal or abnormal, right or left, and then the level of the disease.
Left is abnormal,
for sure. Yep.
right?
So first thing you
is
do, look at those
normal.
ABIs.
Yeah.
Yep.
Yeah, and the waveform is not good starting at the high thigh. So would it be like aorta iliac? Like on that side? Oh, no,
Look
no,
at the
no.
pressure. You know
Yeah.
what? They
hold on.
kind of deceived you with the waveforms. They didn't put a
Yeah.
brachial waveform on here.
Oh,
So look at that. Like, so this
I
one's
couldn't
actually, the
read
top
it.
one's actually left common femoral.
oh, okay. I couldn't read it there.
Yeah. Can I zoom in on that? Let's see.
Yeah, so there's like significant drop from high thigh to low.
Yep. So where would the disease?
Multi-level disease, I guess.
Yep. So it could be, yeah, it could be multi-level. So there could, looks like there's another drop here as well, from going from 90 down to 60, 97 to 69. So I see another drop here and a drop here. So definitely between that high thigh and the low thigh, so femoral artery. And then another drop when you get into the calf.
Okay, like popliteal or something.
Yeah. And so left abnormal, multi-level disease. Good.
Okay.
So back out. All right, Miriam now. So pulse wave spectral Doppler waveforms obtained from bilateral common femoral arteries are measured for rise time. The right rise time is 0.09. Left is 0.19. What is the anatomic level of occlusive disease?
Let me see.
So how would you break down?
A.
So the reason why it's not A is because we have a normal rise time in one leg and then an increased rise time in the other leg. Rise time is that time it takes for the velocity to reach that peak systolic velocity. So it's kind of like a tardus parvus. So when you have an increased rise time, it's that waveform becomes tardus. It's slow to reach that peak velocity. So the side that has the higher rise time is going to be the side that has the disease.
So then it would be the B. The right.
So the longer rise time, the higher rise time.
Oh.
Left. So it takes longer time to get to that peak systolic velocity. So it has a slower upstroke, think of it that way. So it's a more prolonged upstroke or for velocity.
So C.
So C, yeah. And the reason it's iliac disease and not SFA disease, the disease is more proximal to where you're sampling. So always remember that arterial disease occurs more proximal to, where you're getting, your abnormal measurements. So since we're looking at common femoral, we have to look at what's above the common femoral. Does everyone understand rise time? Kind of get it? Wish I had like my chuck.
I forgot about it, but like now that you mention it, like I understand.
Coming back.
Yeah.
Name of the vein. This is Kristen. Originates from the confluence of the anterior tibial vein with the posterior tibial and peroneal veins. So which vein is created from the coming together of the anterior tibial with the posterior tibial and peroneal?
Oh, the popliteal.
There you go. Yeah, it's Lily with her fancy words. Good. Yep, popliteal. Next. There you go, Aretha. What is the threshold diameter for the popliteal artery to be considered aneurysmal?
Is it C?
It's actually going to be smaller than that. It's going to be B.
Okay,
One centimeter. If you kind of remember back to aorto and iliac, aorto like AAA, and then the iliacs were 1.5 centimeters. Aorta was 3 centimeters. Like
Yeah.
to be considered aneurysmal. So if iliacs were 1.5, like popliteal is going to be a little bit smaller.
Okay.
Let's see. This is Lauren. Normal or abnormal?
I'm gonna go with abnormal.
Yep, definitely. That's real monophasic. Like you don't have much phasicity, respiratory variation. Yeah, so that's more continuous flow. So this could potentially indicate an obstruction upstream in the iliac vein. If it's both sides, it could potentially be an obstruction in the IVC. So if you're getting this in both legs, that person probably's got a thrombus in their IVC. So that's a big concern then. Let's see, back to the top. This was now
Is
Krista.
that me?
Yeah.
Would that be the external iliac artery?
Yep. Yep. ECI. Good. This was Karima now. The most common vein used for in situ bypass graft.
The grease
Is-
saphenous vein.
Yep. Very good. GSV. And if we were to take that GSV and flip it the other way around, it's then called a reverse vein graft. And then the other thing to remember with the in situ bypass graft, when you're using the greater saphenous vein, if you leave it in situ in the orientation where it normally runs without reversing it and flipping it, if you leave it in situ, you have to then do a procedure to either remove the valves or destroy the valves, because then blood flow won't go down the leg. Those little valves are in place, to prevent blood flow from going down the leg in its normal anatomic position. So if you're going to use that vein as a bypass graft for an artery to get blood flow down the leg, we have to destroy those little valves, or otherwise blood flow is not going to work. It's not going to travel down that graft. So that's why they came up with the idea, hey, we'll take the vein out, we'll flip it the other way around, and then those valves aren't an issue anymore. Blood flow can flow freely through that vessel, and we can use it as a conduit to get blood flow down the leg. The only problem with reversing it is you have a mismatch now in size. So the vein is larger at the top and smaller at the bottom. When you flipped it, you now have a small top and a large bottom, and you're trying to connect that large bottom to a smaller artery and that small top to a larger artery. So to avoid that mismatch, sometimes they leave it in situ in its correct anatomical orientation, and they just destroy the valves. Who's next? Kim or Miriam, I forget. Your order switched up.
I feel like it's me, but.
It's you, yeah. Which
pressure-
vessel segment? A pressure gradient of greater than 30 millimeters of mercury between the high thigh and the low thigh is suggestive of blank disease.
Like
There you
femoral?
go. It's just like the other one.
Femoral?
Yep. Good. Superficial femoral artery disease. Good. You know, yours is going to be hard now, Miriam. No, not so bad. Normal or abnormal? This is a Doppler of the femoral artery.
Normal.
Yes, definitely. Nice triphasic waveform, nice fast upstroke. So you get a fast rise time. So you have a small rise time. Quick to systolic peak, you know, nice sharp downstroke, nice spectral window, triphasic. So this is absolutely 100% a normal waveform, and velocities, you know, not fast at all. What's next? Kristen? In which bypass graft procedure is a valvulotomy used? There you go.
Oh, hey, you just gave us the answer.
Yep. In situ bypass, good. So this is instrument for cutting valves. Why are you laughing? Who's next? Aretha? Name the perforators.
Is it the Cockett perforator? Or Dodds?
Dodds. Yep, Dodds. So we said, was it Huntering was the thigh, Dodds, and then Cockett were down below, right?
Oh, what's Boyd? It says Boyd's on there.
I'm sorry, Boyd. Sorry,
Boyd.
Dodds were
Oh, I was like,
Sorry.
wait,
Boyd's.
okay.
Boyd's. This would it's Lauren. Photoplethysmography tracing on the fifth hand goes from normal to flatline with radial artery compression. This indicates
B.
radial artery perfusion dominance. Oh. It's B. Yep. So this is our Allen's test. If they were ulnar artery perfusion dominant, that fifth digit, that PPG sensor would remain normal. You'd actually probably wind up with an increase of flow, to be honest, because that flow would be feeding the rest of the hand. Oops, sorry. Oh. Get rid of it. Suitable size for cabbage. So this is a radial artery and transverse. So they're measuring 2.95. So yes, that is a good measurement. So 2 millimeters is our threshold. So below 2 millimeters would not be good for use for to harvest for bypass. So that one would be good. Skip that. And back to Krista. Left brachial artery pressure is 20 millimeters lower than the right brachial pressure. This suggests
Brachial artery is one. Wouldn't it be I like want to say it's lower than the right side. Would it be like stenosis of the left subclavian?
Yes, definitely. Yeah.
Okay. I don't know why that just confused me so much. I'm like,
No, it's good. Yep. So your disease is going to be where you have your lower pressure. So same thing like it would be in the legs. Like you have lower pressure in your one ankle versus the other. The ankle with the lower pressure has the disease or worse disease potentially.
I was
No.
just thinking like with that, like wouldn't that be like steel? Is steel due to a
Yeah.
stenosis?
Yes. Yeah. Steel is due to a
Okay, okay.
stenosis. Yep.
Okay, gotcha.
Yeah, so that stenosis that in that subclavian artery isn't allowing blood flow to get to the muscles of the arm. So since that left vertebral artery branches off that subclavian, it branches more distal. So the stenosis is more proximal. The subclavian vertebral artery comes off that subclavian more distally or past that stenosis. The arm is going to steal blood from that vertebral artery to feed it out to the arm. So that's why you wind up with that retrograde flow and the subclavian steal syndrome when you see retrograde flow in your vertebral artery. So it can happen on both sides. If it's on the right side, the stenosis could potentially be in either the brachiocephalic or in the right proximal subclavian artery. If it's the left side, it's just going to be the proximal left subclavian.
Okay. I was about to say, how would you know like the brachiocephalic from the well, obviously besides like doing that, but like, okay, that makes sense.
Well, you would also, if you could tell, if we want to take it a step further, like for the right side, to be able to tell whether if it's brachiocephalic versus subclavian artery on the right side. If you also had retrograde flow in your common carotid on the right side, or abnormal waveforms in your common carotid on the right side, then it would be even before, so it would be brachiocephalic where that stenosis is, because
Okay.
that's more proximal to both the common carotid and the right subclavian on the right side.
Okay, cool. Thank
So
you.
if you had abnormal waveforms in your right common carotid as well as your right vertebral, then that stenotic lesion is going to be before both of those vessels. And the thing that's before both of those vessels is your right brachiocephalic. So you could potentially see a steal in both the right CCA as well as the right vertebral if it was a brachiocephalic artery stenosis.
It's me.
Yeah. Name the artery.
The deep palmar artery.
Yep.
Okay.
Yep. Deep palmar arch. Good.
Arch.
So the deep palmar arch is an extension of the radial. The superficial palmar arch is the extension of the ulnar. Try this one, Kim. Name the disease. Cold-induced digital vasospasm.
Is that like Raynaud's?
Yes. Yeah. Good. Raynaud's. Very good.
Yeah.
These patients put on gloves, wear thick socks. Miriam. Question number of minutes. During a cold immersion test for vasospastic disorder or Raynaud's disease, a recovery time greater than blank minutes helps to confirm this condition. God, that's a tough one.
I forgot.
Take a look.
I
10
was
minutes.
gonna guess 10 minutes, but I didn't know honestly.
All right. Gonna try another one. Let's close the notes. Another name.
Brachiocephalic artery.
Good. Who's next? Is it Aretha? In the artery?
The popliteal artery.
Yep, definitely. Behind the knee, popliteal. Is the popliteal artery anterior or posterior to the vein?
Anterior.
Yep, good. So, Kristen,
D, the Allen test?
yep, Allen's test. So Addison's test, or Addison maneuvers, part of our thoracic outlet syndrome test. So these are basically both for ruling out thoracic outlet syndrome. And PPG is, our little photo sensor. So good. Yep, Allen's test. And then this is Lauren. Condition: a grossly swollen and cyanotic leg that is caused by iliofemoral popliteal vein thrombosis.
I have no idea. I feel like I should. I have no idea.
I think it's that phlegma.
Yeah, there was no way I was coming up with that.
Phlegmasia. Let's think of a way that we can remember this. There's no way to remember this. Phlegmasia cerula duolin. So this is an extensive DVT that causes the leg to actually become cyanotic.
I saw one yesterday. It just wasn't cyanotic.
Yeah.
But he had external iliac
all the way down.
All the way down. And I tried to comp on it, so that was fun.
Nice.
She made me do it. And I was like,
she wouldn't let you do it?
No, she let me do it. I did the whole
she
thing.
let you do it.
I did the
Nice.
entire thing. And I was sweating and profusely.
Oh.
It's awful.
You know what? I'll be honest, when patients are that positive, it's almost easier. It's like you don't really even have to push that hard. It's like, yeah, there's clot. Yep, clot,
I
clot,
know, but
clot,
like
still clot. Like
it was all, oh my God. Poor man.
I'd rather it be grossly positive than me fishing for a little clot somewhere. He probably wasn't even in really much pain. He was like, "Oh, my leg's probably just really swollen."
Yeah, he said it was just swollen and itchy.
There you go.
Any pain. It was just really swollen.
Back to Krista. So a patient with a dialysis access forearm loop graft. Digital ischemia can result from which of the following conditions? Is there a D? Yes, there's.
I hate to be this person, Dan, but you have the answer up.
I do. Oh,
I'm like,
man.
do I just pretend like it's not there? But I think it's B.
You think it's B? Incomplete palmar arch.
I would have proudly said B.
Yeah, so if we break down this question, this patient has a loop graft in the forearm, and he's got ischemia in his fingers. So if we look at our different conditions that can potentially cause that ischemia in the fingers, pseudoaneurysm would probably occur in that outflow vein where they're actually doing the dialysis in. So blood flow is going up the arm at that point. Thrombosis in the hemodialysis access graft also typically occurs either in that outflow vein or at that venous anastomosis. So blood flow, again, is working its way up the arm. Venous outflow obstruction, that's similar to that venous thrombosis. So the only thing would potentially prevent blood from getting to the digits would be if that dialysis graft is actually stealing blood. So the artery isn't there isn't enough perfusion getting past where you have that connection of the artery and vein going down to the digits of the hand, and it's creating a Steele syndrome. And we're not getting perfusion from the ulnar artery. So typically it's going to be like either a brachiosemina or vesicosemina. I'm sorry, where the radial and the radial artery and the cephalic vein are connected. So with this, so some of the things that could cause, ischemia would be a Steele syndrome as a result of that fistula, and then potentially an incomplete palmar arch. So inadequate perfusion coming down from the other artery, the ulnar artery in this case, or potentially the radial artery, and not perfusing the rest of the hand. So, but all the rest of the other ones would typically happen in the outflow areas, or the blood flow going back up the arm. So that wouldn't necessarily affect or create ischemia in the digits. That one's a little tricky. What's next? Oh, was it Crema, right? Name the artery.
Sorry.
No, it's okay.
The left subclavian artery.
Yep, left subclavian.
What is considered, is it me, right?
Yep.
What is considered to be the lowest vein diameter suitable for an arterial to venous hemodialysis fistula? Is it B?
It's actually going to be C. It's going to be a little bit bigger.
Oh,
So it's 2.5 millimeters, 4 millimeters if it's going to be a graft, an AVG, or an arteriovenous graft. So if you're just doing a direct connection between the person's normal artery and vein, it could be a little bit smaller, 2.5. The vein. Arteries, the minimum diameter is going to be 2.
2. Oh, okay.
Vein is a little bit bigger, 2.5. If we're doing an AVG, arteriovenous graft, then the vein has to be 4 millimeters. So if we're using like a synthetic graft or a man-made graft to connect to a vein, the vein has to be a little bit bigger.
Alrighty.
So yeah, there is a DVT in the popliteal.
Normal.
What is that thing next to it? It looks like a
You're here, right?
no, next to it.
This?
No, on like more to the right. No,
Where's the
that
right?
Be left for you.
Here?
Yeah, I
That?
was looking at that.
Oh, that's more. That's just tissue.
It's under it. Oh yeah, so
There's popliteal artery.
yeah, so
I
it's
guess they're
under,
saying the vein is maybe just there's a valve there. Is that what they're saying? That's a tough picture. I would never give you that on your test.
Mm,
That's tricky.
That is tricky because it
Yeah.
looks like it's partially compressible. Like
yeah.
First
if I was
bully.
to do this area looks like the vein, and this looks like the artery, and this looks like a partially compressible popliteal vein. To me, that looks like partially occlusive. It could be partially occlusive thrombus. I don't know. There's no color flow, so that's a bad picture. Or it could just be there's a valve there. So this could be valve annulus that's not compressing down fully. Or maybe it's chronic DVT. I don't know. That's a bad picture.
Yeah, it doesn't look normal because it would.
No, I would agree with you. I was gonna say, if I had to look at this, I would say abnormal, either partially
Yeah.
occlusive DVT or chronic DVT maybe.
Mm-hmm.
Oh, Lily.
Oh, Lily. I think she's coming back to do some adjunct.
Oh, boy.
We'll have fun.
I feel
Yeah,
like
she
that's
was
so
funny.
like full circle. Like we started with her, we'll end with her. She just missed the
Yes,
middle.
yes. Let me tell you, she's so mellow now and so calm. Like,
It's because she
I
wasn't
don't know,
working
I don't know how
anymore.
she was with you guys, like if she just scared you or if she was tough or mean or whatever, but now she's smiling, happy, like
She wasn't mean. She was just like intimidating.
Yeah, she was
intimidated.
Yeah. Like she made you like, I don't know.
Very
She would-
intimidating.
Yeah.
Very
I would
nervous.
like,
but
yeah.
she was also hilarious.
She was hilarious.
She was. It's funny.
And then like remember like a couple weeks before she retired, she's like, I don't care, I'm retiring. To everything.
And she's carried that over.
It's funny.
She's so happy though, now that she's a grandma, let me tell you. Oh, no, 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 it's damn it. Interpret the data. So resting digit waveform PPGs, right and left. So if I had to interpret this data, right looks normal. Left, we get diminished waveforms, third digit absent waveforms at the fourth digit, and then diminished waveforms again at the fifth digit. Let's see what they say. So abnormal left, 3, 4, and 5. Yep. Which access graph does not require a maturation time? So, vector is impenetrable by ultrasound. Okay. All right. This is a good one. Who's after Miriam? Or no, who doing? You went Kristen. Who's up? Aretha, I think, right? Want to try this one, Aretha? What would you see in this?
Partially occluded?
Yeah. So is this artery or vein?
It
What'd
looks
you
like a
say?
vein.
Looks like the vein to me too. What level are we probably at?
Probably the common femoral.
Yep, I agree. Let's see. Good. Yeah, partially constructed left C coming from a vein. And you can also tell right or left too, based on where the vein is in relation to the artery. So the artery is always going to be more lateral. So if we're in transverse here, this is going to be lateral in the left leg. If we're in transverse in the right leg, the vein would be on the other side of the artery. The artery would be more lateral. So you could tell right and left too, just based on the orientation of the vessels at this point.
Okay.
What's up, Kristen? You want to try? Name the artery.
The ulnar artery?
Yes, ulnar, definitely. And then Lauren, name of test, alternative method to stress the peripheral arterial circulation.
Why do I keep getting these? Um, alternative for a driving. I mean, the only thing I can think of is a PDR-SLP, but
Yeah, well, that is a form of a treadmill stress test. So
that's why I'm like, I don't know.
about the one where we have to put the pressure cuff on the high thigh and just occlude that artery. Remember what that one was called?
No, not off the top of my head.
Reactive hyperemia.
Oh, okay.
I know I like it. I know it, but I couldn't remember what it was called.
Yep, so this is an alternative for a treadmill stress test. So we're kind of creating ischemic changes in the leg to see how severe they are. What was up?
Am I
What's
after
that?
Lauren?
Yeah.
The reflex time would be 3.5 seconds, right?
Mhm.
And then this is abnormal.
Yes, definitely. Yep. Yeah, that's severe reflux. Karima? Name the name of condition. Changes in arterial blood flow to the arms may be related to intermittent compression of the proximal arteries or neural or venous structures. Hint, due to different arm positions. So what is the name of this condition? Name of the condition that describes changes in arterial blood flow to the arms that may be related to intermittent compression of the proximal arteries or compression of neural or venous structures. And this is due to different arm positions.
I forget the name. The compartment, thoracic something. I don't know. Thoracic compartment. No.
Close, yep. Thoracic outlet syndrome.
Yeah, outlet. That one.
Yep. So this is thoracic outlet syndrome or TOS. Sometimes you'll see it abbreviated TOS. So this is the one where the majority of thoracic outlet is actually nerve in nature. So it's neural. It has to do more with the nerve. But it could be due to compression of that proximal artery or proximal veins. And that's related to different arm positions. So you see a lot of times in athletes, especially pitchers that have repetitive motion of the arm coming up over the head, they wind up with thoracic outlet syndrome. But yeah, so it's diagnosed by doing different arm positions when they do an arterial duplex or with the PPG sensors. They'll place PPG sensors on the hands and look for changes in perfusion down to the digits with different arm positions. Or they'll potentially Doppler like at the, the brachial artery, look for Doppler changes in the brachial artery with different arm positions. So it's the Addison maneuver, turning the head from side to side, some other positions. So name of condition. So this is intermittent digital ischemia in response to cold or emotional stress caused by vascular occlusion or stenosis to the digits. So, or stenosis to digits secondary.
Is that like Raynaud's phenomenon or something?
Yeah. There you go.
I keep getting these Raynaud's ones.
It's a sign. It's going to be on your registry.
Oh God.
What was that, Miriam? Name the vein.
External iliac vein.
Good. Yep. elevated or lower. During a SLP study, the pressure may be falsely blank in high thigh of an obese patient. What's up? Is it Aretha?
Would it be elevated?
Yes, definitely. Yep. You got falsely elevated pressures. So if the patient's got a large thigh, you know, that pressure just might be high because they have a large thigh.
Good way to remember that. Might be high
Yeah.
because they have a large thigh.
Gotta get out the big cuffs. Or could even be, well, I don't want to confuse you guys, but yes, obese patients, but even like big muscular patients too. Like if you have a big muscular guy, just the muscle just might be so, you know, dense and thick that it's hard to compress that artery. So the pressures might be just falsely high. What's the condition if we have elevated pressures due to calcification of the arteries in patients who are diabetic or have kidney disease? What's that called? When we get the elevated pressures. So if we have non-compressible, like, you know, ankle and
It's like calcinosis or
yeah,
something.
medial calcinosis. Yep. Kristen? Increase or decrease? Peak systolic velocities gradually blank from the proximal to the distal extremity arteries.
Decrease.
Decreasing. Everything's slowing down. So we're going over this too, like with our first years when we were talking about pressure gradients and like flow volumes and all that stuff. And just everything is kind of slowing down as it exits the heart. The left ventricle is your highest pressure in your body, and everything is gradually going down that pressure gradient. So everything, pressures are dropping, velocities are slowing down, kind of thinking of it as like the train pulling into the station, and the station being the capillary beds where the exchange of oxygen and nutrients occurs. So the train has to slow down, you know, once it pulls into the station at the capillary beds. So everything slows down as, you know, you work your way from proximal to distal. So as the arteries get smaller and smaller, things are slowing down, pressures are dropping. We get into the capillary beds, and then pressures still continue to drop as you work your way back, you know, to the right heart. So when you go from the small venules to the larger veins, you still have a decrease in that pressure gradient because you need that pressure gradient for blood flow to circulate. But velocities, you know, still. But then at that point, velocities tend to start picking up a little bit. Anyway, for arteries, yeah, you got to decrease as they go from larger to smaller, or from more proximal to more distal. What's this, Lauren? Name a vein. Originates on the dorsum of the foot and ascends posterior to the lateral malleolus and runs along the midline of the posterior calf and terminates as it joins the popliteal vein.
Is that the posterior tib? Oh no.
Small esophagus.
Oh,
So origins on dorsum of the foot, top of the dorsum of the foot ascends
Yeah.
posterior.
That was the PT though.
yeah, that's why I'm confused.
Yeah.
I guess the midline of the
So
posterior calf would be
PT would be medial malleolus. So this is lateral. This is like the outer ankle. So yeah, if anything with medial malleolus or posterior to the medial malleolus, that would be posterior tibial vein, posterior tibial artery.
okay. I guess yeah, I missed the midline of the posterior.
Critical ischemia of the distal limb when a patient is at rest. Symptom.
Breast pain? I really don't know.
Yeah, ischemic rest pain.
Oh.
It's silly.
Like,
Anatomy again. Okay. Is the left vertebral artery?
Yep, left vertebral. So it's a branch off that left subclavian.
Yeah.
Or the first branch off the subclavian.
Ugh. Normal?
Yeah, everything looks pretty similar. You know, dichrotic notch on all the waveforms. Nothing looks, diminished in terms of, pressures compared to the brachial. Yeah, definitely normal. Normal PVR and pressures. Miriam, name of artery, branch of brachial artery that runs parallel to the radial artery in the forearm.
The ulnar artery?
Yep. It's the only two we got in the forearm, either radial or ulnar. Yep. Anatomy term. Folds of the intima that temporarily close to permit blood flow in one direction only.
Is it valves? I'm not sure.
Sounds like it, yeah. Good, valves. Veins have valves. Let's see. Kristen?
Common femoral artery?
Yes, yep. Coming from her, good.
I couldn't find my.
Lauren, what is this maneuver called? Blood flow velocity increases with distal limb compression.
Augment.
Yep, augmentation. Back to Krista. Name of condition, blockage of pulmonary circulation by a foreign matter.
Is this like IVC thrombosis or something? I don't know.
So what do we call when we have blockage of what do we call a blood clot when in the lungs when a patient has
Pulmonary embolism.
yes.
Oh.
Yep. Yeah, that foreign matter I don't like. So it'd be, what foreign matter are we going to have in pulmonary circulation? It's going to be a clot, basically. Yeah, pulmonary embolism.
This is the superficial palmar arc.
Yep, you're getting all the anatomy ones today.
Yeah,
Good.
reviewed them.
Yep, so that's a extension of the distal ulnar artery is going to be your superficial palmar arch.
Fluid collection that can be found in the popliteal fossa or upper posterior calf associated with synovial fluid drainage. Baker cyst?
Definitely, yep, that's our Baker cyst. Good. You guys all know what Baker cysts look like? Be able to recognize one? Kind of, sort of. I see Kristen shaking her head. Eh.
Take a
So,
peek at my meat next time we're in there. I'll show you one.
Oh, you got one?
I think so, right? Yeah.
Oh yeah, you did have a little one, right?
Mhm.
Yeah.
Ooh.
Yeah, so I mean, these are, typically you're gonna see in the popliteal fossa, they'll be non-vascular. So when you put your color on, it'll look like a cystic fluid collection. They may have internal debris within it. They may have some small septations as well. So it won't necessarily be completely anechoic, but it'd definitely be non-vascular. Non-perforators.
Forgot. Is it Coggets? Or
Yep, cocket. Yep. Those are the cocket perforators. This is Aretha. Name of two veins.
So the
That's-
first one, is that the brachiocephalic vein?
That's a clavine vein and the right internal jugular vein joined to form the. Yep. So it's
Vein
brachiocephalic vein. Yeah.
To join the
This vein courses vertically downward to join the left
Is it the
brachiocephalic.
axillary?
I'm sorry.
For the last one, the vein courses vertically down to join the left brachiocephalic vein below the first rib to form the axillary.
Go in the other direction. So everything's going
Oh,
towards
I'm
the
good.
heart.
Oh, it's going towards the heart.
Yeah.
Okay.
So your two brachiocephalic veins come together to form.
Internal jugular. I'm getting a brain freeze. I can't remember.
Superior
Sorry,
vena cava. So your SVC.
Okay. Okay.
Picture it now. So subclavian vein and your IJ come together, form the brachiocephalic. That continues downward. So then your two brachiocephalics come together and form your superior vena cava, your SVC.
Okay.
Let's see, Kristen.
Radial artery.
Yep. There you go. So originates at the dorsum of the foot, ascends anterior to the medial malleolus, run along the anteromedial side of the calf and thigh, and joins the common femoral vein in the proximal thigh. That was That was you, Lauren, right?
I had no idea it was even me.
That's okay.
I was like, what?
like-
Nobody answered. Posterior to
Read it slow.
medial malleolus is posterior.
I know, but where does it join?
Common from greater saphenous.
There you go.
There we go.
Good girl.
All right, I was confused. I was like,
And it's posterior to would be posterior to the medial malleolus also. But yes. GSV. Oi. Try Krista.
For some reason, my brain isn't working right now. I'm like looking at that and I'm like, I know what that is, but like,
Oh,
because 5 would be the brachial, right?
yes.
Is there an axillary artery? Am I making that up? I'm making that up.
You're not making
There's
it-
only a
don't-
vein, right? Talk me through this one because I'm.
Ignore Lauren.
Wait, what? Oh, wait, is that. Wait,
Krista,
oh, wait.
Krista.
'Cause 3 is the subclavian, right?
Yes.
So then 4 is the axillary artery, right?
Yes. Yes.
Oh, okay.
yes.
I really had myself convinced that I was making that up. I'm like, there's only an axillary vein. Is there even an axillary vein? My whole life is a lie. Please don't mind me.
Every artery has a vein associated with it of the
Oh, so
same
there's
name.
one of each. Okay.
Yeah, every artery in our body has a vein. So if there's an axillary vein, there has to be an axillary artery
But there's no basilic artery.
there because it's a superficial vein.
It's superficial.
So every artery has a vein of the same name associated with it,
Okay.
and that's what makes it a deep vein.
Gotcha.
So brachial artery has an associated vein or veins. And there's 2 veins, so those are the brachial veins. Radial artery has associated veins. Ulnar artery has associated veins. Aorta has an associated vein, would be the IVC
Hmm.
or SVC potentially.
Seriously, don't
Um,
mind me. I like
yeah.
don't know why I was questioning myself.
Common carotid artery would have the subclavian. I'm sorry. Common carotid artery would have the internal jugular vein. So that's kind of the vein associated with that one. Vertebral artery, when we're imaging the vertebrals, some of us, we are able to see the veins going along with the vertebral artery. So yeah, every artery has always has an associated vein with it. So the artery is your highway taking you to work. You have to find a way to get back home from work. And that's the vein that's associated with it.
Gotcha.
Who's this? This was Kim, right?
It's me.
No, Karima, sorry, Karima.
Yeah.
True or false? Heparin and Coumadin dissolve or lyse thrombus?
I don't think so because heparin like is prevents the thrombus from traveling up, so it's false.
False, yep, good. So these are both anticoagulants, so they prevent clot from forming, but they don't actually dissolve or break up thrombus. So these are not considered thrombolytic medications. So it stops thrombus from propagating or forming, but it does not break up the thrombus. Let's see. This one's Kim now. This one's more obvious.
DVT.
Yeah. Yep. Popliteal vein thrombosis. Good. Miriam, true or false? A positive D-dimer test may not always indicate thrombus formation. However, a negative D-dimer test means an acute thrombolytic process is not occurring.
I think it's true.
Yeah, sure. So just because a patient has a positive D dimer doesn't necessarily indicate that, the patient has thrombus formation. That elevated D dimer could be a result of other things like surgery, trauma. So here we go. These include recent surgery, trauma, infection, some cancers. So there are certain conditions that can give you an elevated D dimer. COVID, perfect example. These patients had D dimers that were through the roof. Didn't necessarily mean that they had DVT, but we were doing all these leg Dopplers for COVID patients because they had elevated D dimers. But unfortunately, COVID did, raise people's chances of developing clots as well. So, but a negative D dimer, means that no acute thrombolytic process is occurring. So if it's negative, good. It's negative, we can rule that out. But if it's positive, could potentially indicate it, but not necessarily. It could be other things. Oh my goodness. Name the artery. Let's see. Is that Aretha?
Is it the posterior tibial artery?
Let's see. It's either going to be that or the peroneal. It's anterior tibial is 9. 10, I would probably say, is the posterior tibial artery. Let's see. It's probably peroneal. Yep, peroneal.
Okay.
I hate these little ones.
It's so little.
Who's this? Kristen. Large venous reservoirs. So name of the vein, large venous reservoirs that lie in the soleus muscle and empty into the posterior tibial or peroneal veins.
The soleal something.
Yeah. Soleal vein, soleal sinuses.
Oh, okay.
Yeah. So I've heard it referred to just as soleal vein or soleal sinuses. Good. Yeah, that's its name from the muscle that it's in. So same thing with the gastrocnemius veins. The gastrocs, they get their name from the muscle that they're within. So they're within the gastrocnemius muscle. This gets its name from the muscle that it's within. And the soleal vein or soleal sinuses, they drain into the posterior tibial or peroneal veins. So it can drain into either one of those. And registry, I know on my registry, they asked what is the most common location for a DVT to develop in, or which vessel is the most common for a DVT to develop in. It's actually these soleal sinuses. So this is the most common vein or the most common location for a deep vein or deep vein thrombosis to form in, is this soleal sinuses or soleal vein. So potentially on your registry, if might pop up. Name a vein, Jesus.
Yeah, what?
Why they gotta flip it up like that?
Like, I don't, what the hell?
Looks like a pretzel.
Is that the anterior tib? I mean, I know it's like, but it looks like it's coming out from behind the knee, like just weirdly, like, what is that? Oh, ah,
I guess this might, wait, are we posterior? Oh, look where the foot is.
yeah, but is that
What's
the,
this?
it's not the lesser staph, is it? No. Why is it flipped up like that? That's confusing. I'm still confused, I think. My
And
brain's
this
not
is
here.
like that vein of Giacchini that connects.
Oh, oh hell.
Yeah.
Uh,
That's a bad one.
yeah, what the heck?
So this is a vein that could, and it's not even present on all people too. That's the funny part. So it can connect greater saphenous to small saphenous.
What is this that I'm looking at?
So which arm position demonstrates positive thoracic outlet syndrome
I'm gonna
results?
say the 180 degrees arm abduction.
Yeah.
It's a wild guess.
I'm gonna go out on a limb here and say which one's not like the other.
That one looks kind of bad. You should see a doctor.
Do you guys know Sesame Street? And that's actually, I'm going back to like when when we were doing my registry review in my schooling, our teacher was always told us, go with the Sesame Street rule. Look at your 4 choices. Which one of these is not like the other? Which one of these is not quite the same? And that's usually the correct answer. So if you have answers, oh yeah, that's kind of same as that, same as that. And ankle brachial index, prima.
Yeah, you say it's, what is it?
What is it?
The ankle brachial index, how to calculate? Okay, we article like the brachial pressure or systolic pressure over the highest like brachials pressure one.
Good.
Okay.
Yeah.
It's the normal value, and you mean the index values? It's between like 0.9 and 1.3.
Yeah.
Okay.
Yeah, 0.9 to 1.3.
Okay, thank you.
So yeah, so it's the ankle systolic pressure over the highest of the 2 brachial pressures. And if you get 2 ankle systolic pressures, you're taking that highest of the 2 ankle systolic pressures. So if you have to choose between posterior tibial or dorsalis pedis artery for your ankle systolic pressure, you're taking the higher of those 2 divided by the highest of the 2 brachial systolic pressures. So that's Kim.
That internal iliac
Yep.
artery.
Internal, yeah, good. Miriam,
Mm,
3 contradictions for a treadmill exercise test.
shortness of breath. Um,
I'm wondering if she put an obvious one on here.
yeah, because I feel like they're not going to be that obvious.
What?
I feel like they're not going to be that obvious.
Let's take a peek.
Yeah.
I'm gonna say something like can't walk or an amputation or something. Let's say.
Put amputation.
Let's see. So cardiac or pulmonary disease, inability to ambulate, so unable to walk. Yeah. Ischemic rest pain, ischemic ulceration, and patients have high blood pressure or stroke. So what about this Allen's test?
It looks normal.
Yep, it's normal. Yep. So with radial artery compression, We get no diminished, we still continue to have pulses, with both PPG sensors. This indicates a complete palmar arch. Kristen? This is normal or abnormal. This is the innominate vein now.
Normal.
Normal, good. Yep. So we want nice pulsatile flow. Yep. We're very close to the heart and to the lungs, so we want that pulsatility. If we saw something flatline, then we'd be worried about a central thrombus. So that's good. We want this. So this is why we always, when we're doing an upper extremity venous study, if it's a unilateral one-arm exam, we always do a spectral tracing of the contralateral subclavian vein to look for this pulsatility, to compare one side to the other. So we're always comparing that symptomatic side to the non-symptomatic side, just to make sure that those proximal vessels demonstrate this pulsatility. Which of the following techniques would be most helpful when performing a vein mapping of the saphenous vein? This is Lauren, right?
Yeah. Doesn't say which one.
What's the page?
I guess it's the small. Be the most helpful. I would say C.
Yeah.
I mean, they all kind of sound like good ideas.
Yeah.
For, I mean,
Well, room temperature, I don't know.
yeah, I don't think that one's like
Gonna
You would
affect,
increase- wouldn't
it's
you-
not gonna affect the vein really.
Wouldn't you increase it though, like to get?
Yeah, you would want a warmer room.
Yeah,
Place patient in prone position, that's not gonna do anything.
yeah. In the upright position, like, I mean,
It's not really gonna do anything for the legs unless like, let's see. Yep, see. If you had them standing, then definitely. If it said like put the patient in a standing position, that would help. So who is that? Krista? What condition? Following repair of injuries to the anterior tibial artery after a motor vehicle accident. Patient complains of weakness in the calf muscle, paresthesia, and pain on passive stretching calf muscle.
Would it be A? Actually, I have no idea. I'm not gonna lie.
No, it's okay. So when patients have particularly motor vehicle accidents or any sort of trauma, the main thing we worry about is compartment syndrome. So that swelling post the trauma, again, creates those excessive pressures within the muscle, the fascia, and can occlude the arteries. So this patient's having arterial symptoms, they're having weakness of the muscle, paresthesia, so that that burning sensation, pain on passive stretching of the calf muscle. So because it's after an accident or a trauma, we worry about compartment syndrome.
Okay.
So if there was no like trauma involved and it was like an elderly patient, then it could potentially be, acute arterial occlusion. something blocking that artery. Oh, these guys.
Patients with chronic.
What does this say? Tracing suggest? God, I even forgot the times.
Is D significant income because it's not 20 seconds
Yeah, right. I forgot what was it?
or greater.
This is when we put that PPG sensor just above that medial malleolus, had the patient dorsiflex 5 times to empty the calf of blood, and then we look for venous refilling.
It's true. It's D.
Yeah. So just based on the choices, it's not gonna, this isn't looking for acute DVT. It's not for, it's not testing arterial insufficiency. So it's either within normal limits or significant valvular insufficiency. So this looks like it refilled fairly quickly. So again, normally it should take 20 seconds to refill. So if the patient had normal valves, this period it took to refill would take much longer. All right, so which of the following is thought to be normally occur in stented arteries?
The A.
Elevated peak systolic velocity. TFE. One parents. Vortex. That's not a good one. Here we go. Our ascending and descending venographies. So again, this is important for us to know also in ascending and descending venography. So in ascending contrast venography of the lower extremity for diagnosis of DVT, the radial plaque material is typically injected into the vein and the who wants to try this one?
Is it the foot?
Yep, it's the foot. So ascending venography, as the name says, the contrast is ascending, so it's going up the leg. Descending venography, the contrast is descending, it's going down the leg. So we're going to inject the contrast in the ascending venography in the foot and watch it ascend up the leg. This is to assess for any sign of DVT. So we're looking to see if that contrast works its way from the foot all the way up. If there's clot anywhere along that pathway, we're going to find it. With descending venography, we're testing to see if the patient has incompetent valves or reflux. So in that case, the contrast, they go into the contralateral groin, the groin on the other side, and run their catheter across to the I guess, either external iliac or common femoral vein on the side they want to assess, and then inject the contrast in the inguinal region and watch the contrast descend down. So they're checking to see if the valves are competent or incompetent. So if contrast works its way back down the leg in descending venography, they have incompetent valves, so we can assess for venous reflux. So ascending venography is to rule out DVT. Descending venography is to assess for venous reflux. Everyone should know this one by now. It shouldn't even be a question. You guys 100% should shout out pseudoaneurysm. They're Dopplering in the neck of the pseudoaneurysm. So it's when you Doppler the neck is where you get that to and fro flow. So you should be able to recognize that waveform. Treatment for this is going to be our thrombin injection. And where do we inject? We inject as far away from this neck as humanly possible. So within that pseudoaneurysm itself, away from the neck. We don't want to inject in the neck. We don't want to inject in this native vessel, because then we can have thrombin work its way into our native artery. It's going to go down the leg, and then we have problems. We'll wind up occluding the patient's artery, their native vessel, if we get thrombin into there. Does anyone get to scan a pseudoaneurysm yet? Has anyone ever done one? No. Has anyone seen one yet? No. Okay. You did, Miriam?
Yeah, I saw one. It didn't really look that obvious though.
Really?
It was small. Yeah.
It was
I think
small?
it was in the yeah.
It was in the arm?
Yeah. It was
Oh.
like really small, obvious at all.
Okay, yeah. So the ones in the radial, like that might have been post-radial cath. Those are typically very small, to be honest.
Mhm.
I had an old guy come into the ER. He had in both groins, and they were huge. They were like over 10 centimeters or 13 centimeters. And you could see it like in both groins, and they were discolored and huge. And like, I guess his doctor was like, that's fine. Like, cause he'd been like that for like over a month or something like that. Like, I don't understand, but. All right. In the presence of arterial obstructive disease and digital ischemia. So in the presence of arterial obstructive disease and digital ischemia, vasoconstriction increases, distal resistance decreases. All right, so the way this question reads is a patient has arterial disease, peripheral arterial disease, and they have poor blood flow getting to their hand or their feet. So they have digital ischemia. So the body's response to this digital ischemia, in order to get blood flow down, to the hand or to the digits, those blood vessels are going to want to dilate. So the body's going to be like, hey, my hand's not getting enough blood flow. So it's going to cause those vessels to dilate. There's going to be vasodilation. And then if the vessels are now dilated, that distal resistance is going to decrease. So we'll have nice open vessels. So we'll have decrease in peripheral resistance and increase in vasodilation. So answer should be C. Yep. That kind of makes sense to everyone. Which of the following is not a result of the data below? So we get a high thigh pressure that's significantly lower than the left high thigh pressure. So the first thing you know, disease is on the right, because that's the side with the lower pressure. since the left high thigh pressure is normal, we can automatically exclude one or you can, if you look at your choices, you could figure out like, which one it's going to be. You can automatically exclude aortoiliac because it's not the aorta because the left side's normal. And if you look at the other choices, has to be all the other choices could be potential options. So the other ones could potentially be correct. So which one is it not? It's going to be the aortoiliac. So all these are above that level of the high thigh. Oh, these guys.
Okay.
Our photoplethysmography with and without a tourniquet with venous refill time.
Oh,
I
okay.
literally hate these.
I know.
Is A because I don't know.
So photoplethysmography was performed on your patient. Venous refill time was 10 seconds
Yeah.
without a tourniquet. So, all right. So that's
Abnormal.
positive for reflux.
Yeah. Abnormal.
It's 25 seconds with a tourniquet applied to the lower thigh.
Mm-hmm. So and it gets to be normal because it's greater than 20.
Yeah.
So, yeah. So it's A. Absolutely it's A, I think. Yeah.
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 Yep. So when we apply that tourniquet, we're cutting off either the greater saphenous, and if we put the tourniquet below the knee, it's the small saphenous and the GSV below the knee. So yeah, so it's going to be A. So it's not looking for thrombosis, so we can cross those off automatically. And it's either going to be deep valvular insufficiency or superficial. If it still was a fast refill time, so if it was less than 20 seconds with the tourniquet above and below the knee,
Yeah.
then it can be deep valvular insufficiency. Who wants to try this one? Someone want to give it a shot? See, all of the statements below are accurate regarding an arteriovenous fistula, except so there's an increase in volume of blood flow in the feeding artery. Let's say yes. So our inflow artery, we see elevated peak systolic and end diastolic velocities. So we have increased flow in that inflow, that feeding artery. Arterial resistance proximal to the fistula is decreased. So that's true too. So that artery before the fistula, we have low resistant flow. So normally it would be a high resistant, but if we have a fistula, we have now a low resistant flow because it's feeding into that venous system.
Let's see.
Yeah, I would say C. Pressure within the venous drains is decreased. I'd say we have increased pressure now. We have arterial flow going into it. So D, a high output cardiac failure is common with a large AVF. So now we have a lot of blood flow going back up to the right side of the heart. So we shunted a lot of blood flow. So we can wind up with patients that have cardiac failure as a result. So you're putting extra strain on that heart.
Basilic.
Basilic, yeah,
Oh, I thought it said artery. Yeah, basilic.
yeah. You recognize it. So brachial artery, brachial veins, basilic vein. I hate these cuff sizes. Skip it. Which term describes pale skin color due to insufficient blood flow?
It's,
Isn't that like pallor?
Yep.
yeah, it's the,
During Valsalva maneuver, the normal Doppler response for the femoral vein is,
C.
yep, cessation of flow. So Valsalva will cause cessation in both the upper and lower extremities. And then release of Valsalva would be augmentation. What does that look like?
Lymph node.
Lymph nodes, yep. Inguinal lymph nodes. Almost done. Which of the following is a sign of normalcy in subclavian vein that is usually not present in the lower extremity veins?
Wouldn't it be B?
Yep, prominent cardiac pulsatility. Very good. What should be the patient's position when you're taking the ankle pressure?
Supine.
Supine, yeah. What is the name of the non-atherosclerotic, non-inflammatory occlusive and aneurysmal disorder that primarily affects women and is referred to as a string of beads or string of pearls appearance?
It's B.
Everyone should know this one.
DB.
Yeah. Fibromuscular
B. Yeah, fibromuscular dysplasia. An aneurysm resulting from infection is known as a
mycotic aneurysm.
mycotic aneurysm. Yep. Addison maneuver.
I still remember this. The military something the patient assumes. Yeah, C. No, D. I think it's, I don't know.
D.
Yeah.
So patient's arm is at a 90 degrees to the torso. So they're kind of like out like that. The head is turned towards the affected side and then away from the affected side during deep inspiration. And they do all these other ones as part of the thoracic outlet syndrome test. But this specifically is that Addison maneuver. Just the patient's at 90 degrees with the head turned. Which of the following types of plethysmography detects cutaneous blood flow by sending infrared light into the tissue? This we know. This is photoplethysmography.
Yeah.
So this is not a true form of plethysmography. So all the other ones measure volume changes. So plethysmography measures volume changes. So when we do our PVR SLP exam, the pulse volume recording, we're actually measuring volume changes of blood as blood enters and exits the calf. It displaces some of the air in the cuff and actually measures the volume of the blood entering and exiting the calf. And that's what actually creates our little tracing, our waveform tracing that we get with plethysmography. And again, if they give you a question on your registry or on your exam, looking at waveforms, you can tell the difference between a plethysmography waveform, a PVR waveform, and a Doppler waveform by that zero baseline. So a Doppler waveform is going to have that zero baseline on the trace lean. So you can tell if it's triphasic, you know, monophasic. A plethysmography waveform will not have that zero baseline. So you'll just see the little boxes in your waveform. So it'll be like that box chart, you know. So look for that zero baseline to tell the difference between a plethysmography waveform versus a Doppler waveform. Which syndrome results in medial displacement of the vessel due to compression by fibrous bands or the medial head of the gastrocnemius muscle?
So B.
It's the popliteal entrapment syndrome.
Mm,
Can I say that?
57-year-old male presented with vascular lab for lower extremity arterial testing. Exercise testing was stopped due to symptoms of claudication. Post-exercise ankle pressures measured slightly above resting ankle pressure. What is suspected in this patient?
Is B?
Yeah, B,
Yeah.
a non-vascular cause.
Just
Good. So if it was a vascular cause, we'd see lower
Abnormal,
pressures. So
yeah.
the fact that they were slightly above, you know, means that this cause of this guy's symptoms is not going to be an arterial issue. Pulse palpated in the groove behind the medial malleolus of the ankle corresponds to which artery? So posterior to the medial malleolus, that's going to be our posterior tibial artery. So we don't typically palpate peroneal artery. Bursaspidus, we know where that is on the dorsum of the foot. This could potentially palpate the anterior tibial artery. So a dampened waveform demonstrating a delayed acceleration time is obtained in the common femoral artery. What is the most likely reason for this finding?
B? Is this some conclusion?
I think it's A. Yeah.
Mm. Inflow disease.
So this is describing a tartus parvis waveform. So it's a dampened waveform. So we have low velocity with delayed acceleration time. So that's going to be a tartus parvis waveform in our common femoral. So we have to think about what disease is going to be proximal to that. It's definitely not pseudoaneurysm, not exercise. Distal occlusion could cause a dampened waveform, but it's not going to have that delayed acceleration time. It's just going to be that sharp systolic thumping. So you'll have the little spikes, the little peaks.
Yeah.
So inflow disease, again, that's going to be blood flowing into the leg. So these are the vessels that are affected by inflow disease, or considered inflow disease would be your aorta, iliac, up to the level of the common femoral. And then outflow disease is going to be, your femoral popliteal. So outflow disease is flowing out towards the foot. So into the leg and out to the foot. That's kind of how I remember it. Outflow disease is out to the foot. Inflow is into the leg. So your groin is kind of like your demarcation between inflow and outflow disease. Arteriography is contraindicated in patient with
Renal failure. See?
renal failure. Yep. Because of that contrast, we can't administer the contrast because they're in renal failure. We don't want to damage the kidneys further. So yeah, so we're not able to do an angiography or arteriography. So a potential option for this patient could be an MR or an MRA without contrast. So that's a possibility if they don't have any metal. So in reactive hyperemia testing, the blood pressure cuffs are inflated to suprasystolic levels for how long? That's going to be C, 3 to 5 minutes. That's why it's not well tolerated, because you have to have this cuff inflated, to above systolic pressures for at least, 3 to 5 minutes. Patients are screaming at you. Transverse image taken from a patient's right lower extremity near the groin. So you guys should all know your vessels by now.
The common femoral vein.
Yeah, common femoral vein, common femoral artery, greater saphenous vein. So again, you could tell right and left. If I'm in transverse, the artery is always going to be lateral. So I can tell that, this is going to be the patient's right leg. You kind of just visualize, where the artery is in relation to the vein. And it'll become second nature to you, being able to look at it and be like, oh, that's right leg, that's left leg. Which type of bypass graft will cause size discrepancy between the graft and the native artery at both the proximal and distal anastomosis sites? What do you guys think?
B.
B, yep, that's the reverse vein graft. So this is the reason why sometimes they choose to do an in situ vein graft, because of that size discrepancy. With patients standing, what time value is threshold between normal and abnormal for reflux in deep veins? So it's going to be C. 1 second. With GSV or the superficial veins, it's 1/2 second. With the perforators, it's even less. So if you're on your registry and you see reflux greater than 1 second, regardless of what vein it is going to be, it's abnormal. It's considered significant reflux. So if it's greater than 1 second, if you see reflux greater than 1 second, no matter what vein they're showing you, they're going to try and trip you up. It's going to be, considered abnormal or significant reflux. Which of the following vessels is not usually used in hemodialysis? Fistula, axa, used in hemodialysis hemodialysis access graft or fistula. So what do we typically not use? So we typically don't use that median antecubital vein. Definitely use, I'm sorry, not that one, brachial. I didn't even see that. I thought it's a brachial artery. So we may use median antecubital vein. We typically don't use a deep vein for dialysis graft or fistula. So we like to use superficial veins. Part of the reason being, again, the most likely source of thrombosis within a fistula is going to be in that outflow vein or the venous anastomosis. So if we're connecting to a deep vein, we're now running the risk of giving that person a DVT as a result. So we don't want to do that. On duplex exam, a 55-year-old male, a thrombus is seen in one of the gastrocnemius veins. Which vein would most likely be involved in the propagation of this thrombus?
C.
C, yeah. Gastroc connects to the popliteal vein. What is the term for persistent inflammation of the skin around the ankle with a tendency towards a brown pigmentation? So this is going to be that stasis dermatitis. So this is venous stasis dermatitis. And you see that brown pigmentation around the ankle. So that's that gator zone. It's going to be stasis dermatitis. A technique whereby atherosclerotic plaque is mechanically removed by cutting or pulverizing it and then extracting it by suction or downstream embolization. This technique is called
C, arterectomy.
atherectomy. Yep. So endarterectomy is when we actually surgically open up the artery itself, remove the plaque, sometimes the portion of that inner lining, and then sew the artery back up. So that's the endarterectomy. Angioplasty, we know that's with the balloon that inflates multiple times to kind of smush that plaque up against the walls to reopen the vessel. And then thrombectomy is something that we would do with soft thrombus. So they kind of pierce the thrombus, go past it, like open up like this, almost like basically like a balloon again, and just kind of retreat the catheter or pull back the catheter, and it takes that thrombus with it. So thrombectomy has to be done with something small, soft, so not this hard atherosclerotic plaque. So the arrow is pointing to this one.
Deep. Is the deep femoral?
The femoral, yeah. In the lower extremity, maximum venous flow return in the venous system is present with
Expiration. Expiration.
I would say, yeah. Expiration. Yeah. Common graft configurations include all of the following except I You can see tibia. So we can do a fem bypass, go from the right femoral artery to the left femoral artery, or vice versa. We can do from the femoral artery to the popliteal artery in the same patient on the same side. We can go all the way from the axillary and bypass the iliacs if that's where the disease is, or the aorta, and connect to the femoral artery. So this is all in a matter to get perfusion, down the leg, down to the foot. So we can't go from the tibial artery on one side to the tibial artery on the other side. So just to refresh, a nuclear medicine screening test that detects perfusion of the lungs is also known as, it's going to be that VQ scan, the ventilation quotient scan. So we use this as to determine the probability of pulmonary embolism. So it's graded as no, high, low, medium, or high probability. So this is a nuclear medicine test where the nuclear radiotide is either inhaled or injected, sorry. Which of the following is the most common cause of thoracic outlet syndrome?
Nerve compression.
Yeah, so it's actually nerve compression. So a lot of people would think like veins are more easier to compress than arteries, so it's got to be venous compression. But actually, the most common cause is going to be nerve compression. So it's more commonly a nerve issue with thoracic outlet syndrome than a vascular. The greatest danger from vein thrombosis is, this we should all know. Yeah, pulmonary embolism. Longest vein in the body, we should all know. Greater saphenous vein, shouldn't even be a question. Most valves, in vein with the most valves, again, greater saphenous. Normal versus abnormal. That looks like a beautiful, healthy peripheral artery waveform. Nice triphasic, nice spectral window. That is 100% normal. 85-year-old male presents with an abdominal bruit and bilateral weakness of the lower extremity, bilateral weak lower extremity pulses. Diagnosis. We look at his little chart here. We see they're low at all segments, particularly if we look at the high thigh. I mean, they're similar. So it's not one leg worse than the other. And the lower pressures start at the high thigh. So the disease is going to be above that. So aortoiliac disease. D. Technologist performing a venous study on the lower extremities notes that color Doppler does not demonstrate the calf vein filling spontaneously. What technical factors could be adjusted to improve the color display? This is physics. So improve color display, increase color gain, decrease our PRF.
Decrease color filter.
Decrease color filter, so C. So we want to lower our filter, have a low pass filter. Which of the following is a common feature for temporal arteritis?
Would that be B?
B, intima thickening, I think, yeah. It's B. Yeah.
Yep. So arteritis is inflammation of the arteries, inflammation of that vessel wall. So yeah, so you wind up with intimal thickening. Toe pressure 30 millimeters or less indicates.
Poor
That's
hip
yeah,
potential
poor healing potential.
for foot orthodox.
So that's a very low pressure. If we have arterial calcifications due to diabetes, that could raise our pressures. So that'd be medial calcinosis. So we'd have high pressures with that one. It's not normal. So that's a very low pressure. And low pressures do not indicate good healing potential. Patient should be positioned for duplex evaluation of the lower extremity veins.
U or D?
Yeah, reverse Trendelenburg. Want the feet lower than the thighs, feet lower than the head. So this is a longitudinal picture of the common femoral vein. So what would this diagnosis be?
Thrombus?
Yep. So it looks like potentially a partially occlusive acute thrombus.
Okay.
Yep. So if it was just a couple linear echogenic echoes and this vessel was almost completely filling, then you could potentially call it a chronic DVT, but this is, definitely a big acute thrombus. There you go. The most common origin of thrombus formation. Oh, I left.
Yeah, you said that one. So insane.
Soleal sinus. Yeah, so that's going to be your the soleal sinus. In venous ultrasound, how is the transducer compression best performed?
It's A.
Yep, B mode, transverse orientation. What is indicated by the presence of a brewery?
D.
So brewery has to be caused by turbulent flow or fast blood flow. So anywhere that blood flow is not moving is not going to cause a brewery. So arterial occlusion, there's no blood flow going, that's not going to cause a brewery. Thrombosis, no blood flow is moving, so that's not going to cause a brewery. Absence of arterial disease, that's not going to cause a brewery. So you need turbulent flow. So that's the only thing that's going to cause turbulent flow. What is the most common cause of upper extremity venous thrombosis?
B.
Yep, it's going to be intravenous catheters, lines. So that's the main reason you'll see in the vascular lab why they scan the arms. These patients have had PICC lines or IVs, or multiple bloods drawn. So even if they don't have an IV in, ask them, was there an IV anywhere? Have you had multiple bloods drawn recently, repeated needle sticks? Because that's going to be your most likely cause for upper extremity thrombosis, that repeat jabbing or intravenous catheters and lines. Holman sign. So what is it? This is that so that's that hyper extension of an extremity. I'm sorry, not, it's dorsiflexion of like the foot. So it's calf discomfort, non-passive dorsiflexion. So when they kind of point their toe up, they get calf discomfort or calf tightness. It's an old school sign of, saying that a patient could potentially have a DVT, but it's not very reliable. Oh, this is an interesting one.
Gastrocnemius.
Yeah, gastrocnemius arteries.
Yeah.
Good. All right, we're almost there. Home stretch. Blood flow from the deep vein system will back up into the superficial system when
See?
yep, my perforator veins are incompetent. So normal blood flow in perforator veins is from superficial to deep. So when they're incompetent, it goes from deep back into the superficial, and you wind up with varicose veins. So that would be secondary varicose veins due to incompetent perforators. How should a patient be positioned to facilitate visualization of varicose veins? That we want them standing. That'll help. That's your best answer. Reverse from Bellenberg could also be a potential answer, but best one is standing. What is considered the lowest vein diameter suitable for a vein graft? So for an AVG, that's going to be our larger one, 4 millimeters. For a fistula, 2.5. The artery itself, radial artery, would be 2. So this one's going to be D. In contrast, venography, which finding would indicate the presence of thrombus?
Filling defects.
Yep, filling defects. So we look for filling defects within the vessel. Increase opacity, so increase of contrast filling. That's what we want. We want the vessel to opacify or fill completely with contrast. Contrast extravasation, so that's a leaking of contrast out of the vessel. So that could potentially indicate, like a pseudoaneurysm or a hemorrhage or a rupture of a vessel. Color display is not an option for contrast venography. Thoracic outlet syndrome, which of the following is the most important arm position? I'm just going to guess. I would say the symptomatic position. Do what hurts them. Like when they have their pain, when they experience the pain, that's where you want to try and reproduce the symptoms and see if it's an arterial or venous issue. Or a vascular issue. So you always make sure you do your symptomatic position. Symptomatic positions. God, I had to fight a radiologist in New York because he wanted us to image the asymptomatic side on patients first, as opposed to doing the symptomatic side. And I was like, this makes absolutely no sense. This was a new radiologist that came in. It's like, I want to see what normal looks like first and then abnormal. But no. Like, what if we don't even have time to image the abnormal side? Like that's besides the point. What do these common femoral artery waveforms most likely represent? So let's look at these common femoral artery waveform. Or what? So we look at the common femoral on the left, looks normal. We get a monophasic on the right.
I can see them.
We can zoom in a little bit, so it's probably tardus parvus. Well, regardless, we go from normal triphasic, so this is normal. And then we have monophasic on the right. So we already know that we're after some sort of stenotic lesion. So we're post-stenotic over here. So we have post-stenotic waveforms going down the rest of the leg. So if we're just looking at the common femoral artery, let's see what our choices are.
Inflow disease.
I think this is a patient who has Berger's disease. No, because Berger's disease affects the digits.
Is D?
We suspect a patient has an acute occlusion of her aorta. Oh, so it's a female. You know, it's a female. Yeah, so D, I would say, has inflow disease of the right lower extremity. So if we're just looking at the common femoral arteries. D, yep. Yes. What is the most significant arterial disease of the left lower extremity?
C?
So now we're just looking at the left lower extremity. Just the velocity. Or
It's B.
popliteal to posterior tibial.
Mm.
Yeah, I would probably say B. It's a B. So it looks like our waveform changed most drastically going from our popliteal down to our posterior tibial and dorsalis pedis. So we went from biphasic to monophasic, very diminished, almost no, pulses. So the disease is, from this calf level to that popliteal level. So anywhere in between there. So pop, infrapop. It's going to be above, above those posterior tibial. Patient is scheduled for lower extremity bypass graft. Which of the following choices makes the most suitable which of the following choices would make the most suitable bypass material?
A.
B. Because it's the most like huge one there. So I can say B. I don't know.
It's like,
It's because
I'm
for
not
me,
sure about which of the following choices would make the most suitable bypass material. Yeah, I would.
yeah, it's the biggest one.
Yeah, all the other ones are too small. They're really too small. I mean, that's the only one that's close. And last one. Lower extremity arterial stenosis. If P systolic velocity at the region of stenosis is measured at 300 centimeters per second, what would the pre-stenotic peak-systolic velocity have to be for stenosis to be considered greater than 75% diameter reduction?
Let's see. 17, 75, because it's the ratio should be like between 3 to 4. Greater than 4.
Yep.
Yeah. So 75.
Yeah, so if it doubles, so if it went from 150 to 300, that would be considered a 50% diameter reduction. 75%, yeah, she's right, it's 4 times.
4 times.
So that's about a 4 times increase. That's it. This stuff kind of coming back to you guys a little bit,
A little bit.
Yeah.
a little bit.
That's it.
Have you done any review yet for like any of the other classes? Not really. It's all good. This is all going to be good practice.
Yeah.
So next week too, I'm going to go over specifically some of the diagrams that are going to be on the final, just so everyone's good at, so there's no surprises. And
Thank you.
guys are going to be fine. Any clinical issues that I need to address, or does anyone need to go to like any sites to like make sure you get what you need? Yes. Where do you need to go, or what do you need?
I need to go somewhere general.
General.
I need like I've done a whole bunch of things, but I haven't comped on all of them. Like I've done like 1,000 scrotums, but I never like comped on any of them. And when I would
Cool.
ask to comp, like the patient would refuse, or the tech would be like, no, not this time. I'm just like, okay.
Oh, that's nice.
And like first
So-
trimesters, the 2 times I tried to do it to comp, they were fetal demises.
Oh,
So
God. Yeah, you don't want
I'm
to
just
do
like,
that.
what? I didn't have any luck. I would do them on other patients and it would be fine, but I didn't ask to comp ahead of time.
So where do you guys think would be the best place to send her? Like where are you guys now? I gotta pull up your charts.
I mean, Wilmington, I got
Probably at
a lot of stuff.
107.
Yeah,
Yeah, I
probably
would say
either
Wilmington
Wilmington or
got
B120. I mean, I'm not super excited about going back to B120, but
Wilmington, they had a lot of first trimesters. They had
Yeah,
a
I
lot of
agree.
scrotums,
yeah.
like general stuff. Like you can get pretty much all. I mean, I don't. The first trimesters, they're not like.
B120 first tries, they're probably gonna all be at OB triage, which you can't go to early
Yeah.
anyway.
Yeah.
Oh,
Yeah.
yeah, that's
Like,
right.
I would just, if you need to do one, I would go to Wilmington. Same thing with
Yeah.
scrotum. Like I think I got my scrotum, like Michelle will let you do anything.
Mm-hmm.
And I
Yeah.
think I actually did that one with
Yeah, she let me do one last semester when I was there, but I mean,
Yeah.
I didn't need to
Is
comp on
anyone
it.
at Wilmington now?
I am in Wilmington and I'm not able to do any one because I don't know, maybe because of the break that we had and I couldn't see any scrotum. I saw just one, demise like first trimester and going very slow there.
I got a ton there. I don't know.
Yeah, it's going slow.
Okay.
What about
I think where could we move Karima? Let's pull up our thing.
I need
you also
to
could
do
do
scrotum and first trimester.
yeah, HCC?
Oh, she needs to.
probably do.
Yeah.
That's
Or,
what I was saying.
107, there was a lot of scrotums, but I don't know
Yeah,
like
same with
what that looks
HCC.
like. But
Never seen one.
Maybe when I go in, I can stop at 107 and see what her schedule looks like,
Yeah, that's good.
since it's in the hospital anyway. I just need to make sure I bang out my vascular comments quick. I got 1 ABI already, so
Good.
got 1 down.
And the PVR you can do here.
Mm-hmm.
and did the on one.
Also, like for like the vein mapping and like the insufficiencies, like what are we like?
We're
Are
just
we, like,
observing, right?
well, maybe not the insufficiencies, but I know like the vein mapping, we have a
That's
comp to do. Like, is that like, are we like pressing for that? Like, or like, you know what I mean? Like, is that something that we have to get done this semester or?
No, that can be done next semester. Yeah.
Okay.
That's
And-
what I wanted you to say, Dan.
Yeah, we
Yeah.
just need one, I believe the vein mapping, we need on one patient in the hospital. So like one comp for vein mapping. Like by the time you graduate.
Perfect.
At least that's the new like KHEP accreditation things. You guys are gonna be shocked when I show you your new competency list, like when we sit down next week.
Oh,
It's gonna be like,
Like a good or
Oh,
bad
like
job?
no, good, good. And it's gonna be like
Yeah.
severe, like much less than like,
I'm so excited.
God.
you're not gonna need to do like 6 livers or anything like that. Like, we
Oh,
just need
Well, that's good,
one.
because I haven't,
Because you guys have done them.
Haven't
You guys
done
have done them.
4.
Like, you
Yeah.
guys are essentially been done. Like, so like the way going forward, it's you just need to do it once, like, your second year. So like whether you do it first like fall or spring, it's gonna be like 1 liver, 1 gallbladder, like, one kidney, one. So we don't need all these multiple comps anymore.
I-
Like, so then it'll give you more time to focus more on like, the OB, getting your OB stuff, getting your vascular stuff. So having to do all these multiple abdominal ones, like we don't have to, do that anymore. So that's good.
okay.
So as long as we can get you one of all of these, like, even I'm not even so terribly concerned about you finishing them all this semester. As long as we can get them done by the time you graduate, that's all we need is we can have proof that you've done this on a patient. You've been graded by someone from the clinical site of your clinical instructor that, yes, you're competent, you've done it on a patient. That's all accreditation wants to see, and they want to see that, yes, she's done it on a patient. She's good. She's been evaluated, she's competent in doing this.
Okay.
So I'm even not terribly concerned about like having to finish all of these, this particular semester.
Okay.
So I know you guys have done an awesome, phenomenal job, doing what you can and getting what you can. And Miss Lauren and Krista and Karima finishing all their OB comps. Like,
It was close. I have to do 2 more, but I was close. All right. Well, you said you're gonna send out a review for the, like, you're gonna send out a review for the final next week.
yeah. So next Monday, we have just to do the cerebrovascular review, and we'll go over the diagrams
Oh, Monday. We have class Monday.
Monday. Yeah. So we're
Oh.
gonna come in. So we'll come in, I guess, want to start at 9. Is that good?
Sure.
Yeah.
Yeah, we'll start at 9. We'll just do the cerebrovascular review, flow through that, and then we'll have I'm gonna send out a sign up for I guess the clinical evaluations, the final clinical evaluations.
You said this is Monday, right?
So I'm gonna do half on Monday and then the other half on Wednesday.
Okay, I just want to remind you that Monday and Wednesday, I'm gonna have to go to clinical.
Okay.
So just
Which
however you want to work that out.
All right. So I'll slot you into one of those first ones then.
Okay.
And if anybody's around, I'll do my PVR on one of those days
Sure.
on whoever's waiting.
Yeah, we'll steal. All righty.
Thank you.
Cool.
You're welcome. I'll
Bye.
see you all next
Bye.
week.
Just then, please, I don't know. I want to remind you if you can like contact I about the. I know that you are busy now with your family, but if
Oh, it's
you,
okay.
thank you.
So Io, she still didn't do it for you yet?
No.
Io. All right. I'll send her another message.
Oh, thank you so much.
Hold on, let me check if Tanya's done it.
She didn't do one for you either?
Oh, for vascular people, I'm just taking the paper in. I'm not
Okay.
even messing around with those people. I should have done that with Tanya, but let me check if she actually did do it or not. Because I left her a note.
Let's see, Tanya, I'll check.
Yeah, she didn't do it. Thank you so much. And
Okay.
I'm so glad of your family safety. That's the
Yeah, no, thank you. Yeah, I
Yeah.
appreciate it.
Yeah, bye. Have a good one.
Thank you, you too.
No, Tanya has not done them. So do you want me to email her or do you want to?
No, I'll send one out to her too. Doing that right
Okay.
now. Tanya
All right.
Tweedy. All right.
Thank you. I'm glad. Yeah, I'm glad your family is okay.
Yeah. Yeah, just
Especially your
gotta,
daughter. That's so scary. Oh my God.
yeah, she was terrified. Like I felt horrible for her. Like, but yeah.
Mm. Well,
She had like little cuts on her tongue. I guess she bit her tongue a little bit. So I was like, you need ice cream. That's gonna make it feel better. So like she came home when we got back home. She's like, where's my ice cream? She remembered. So
yeah, no, they don't forget. All right. Well, take care and yeah, enjoy extra hugs with your family.
thank you. I'll see you.
All right. Bye.